presents to the, okay, I'll start again. So the first aliquot is 96-year-old male presents to the ED brought in by his home health aide with bilateral leg swelling. Do you want more details, or do you want me to stop there?
Thank you, Marina. Thank you so much for presenting. Maybe you can just give us a little bit more information, so
Okay,
just to honor the time. Thank you.
sure. The patient's aide noticed new bruising in the lateral aspect of the left calf 4 days ago, prior to the presentation to the ED. The patient's aide was unaware of any trauma to the area or recent cough. And for the past 2 to 3 days, the patient has had worsening bilateral leg swelling. She decided to watch the patient and tried ice and compression stockings, but as the patient did not improve, she decided to bring him to the ED. The patient has complained of dry cough and runny nose for 2 days, denies chest pain, shortness of breath, abdominal distension, or palpitations.
All right, thanks so much, Marino. I'll just start with the leg swelling and then have the amazing Dr. Penner layer on the rest of the HPI. So, the first thing I note is that just the patient age, 96 years old, incredible. And also it means like this person had 96 years of experience and the body has been going through 96 years. So this patient's like has medical history and also just like more prone to pathology. And in terms of like a bilateral like swelling, we oftentimes, and I think I learned this from Robbie as well, is that when it comes to bilateral leg swelling, the first thing he tells us to do is to look up. And then because the 3 organs that internally that we worry about when it becomes to bilateral leg swelling is the kidneys, the liver, and the heart. So looking at the JVP, looking if the patient is dyspneic as well to see if the heart is in the hook, to kind of look for evidence of estrogenemia, to see if the liver might be in the hook, and the kidney is like kind of the silent one. Unless like is anasarca and we're worrying about a nephrotic syndrome, most likely we'll catch that on labs. However, there are more rare causes that can also lead to bilateral leg swelling. A diagnosis of exclusion is always like venous insufficiency, and there's some vascular pathologies that can also lead to it. And for that and for the rest of it, I'll just pass the mic to Jack.
Oh, I have nothing to add to your approach to the bilateral leg swelling there. I mean, that was absolutely phenomenal. I think like one of the things that's jumping out to me is that there's also this chief concern of bruising in the legs. And I think it's challenging to know what exactly to do with that right now. As Charmaine was saying, if we just go from an epidemiologic perspective and say, can things that cause lower extremity edema also lead to bruising? And I think the answer to that is absolutely yes. One of the most classic examples we have of that is some of the skin changes that we can see in association with chronic venous stasis, where we have increased hydrostatic pressures within the vessels, and that leads to leakage of fluid. And sometimes you can also have leakage of blood into the subcutaneous tissues. And we can see things like hemosiderin deposition in the subcutaneous tissues, and that can give people with venous stasis that sort of ruddy brown or bruised appearance to the bilateral lower extremities. So I think one hypothesis is that we can say, okay, what we're dealing with is a syndrome of bilateral lower extremity edema, and that may be leading to the extravasation of some blood vessel or blood cells in addition to fluid outside of the blood vessels. Whereas the alternative hypothesis is that this is a syndrome that can cause bilateral lower extremity swelling and is also causing a coagulopathy. And I think really there's 2 things that are going to help us make progress on distinguishing between these 2 hypotheses. One is going to be whether or not on exam we detect the presence of bruising or bleeding in other tissues in the body. For example, do we see things like gingival bleeding? Do we see petechia on the soft palate? Or do we see atraumatic bruising elsewhere in the body? And that will give us a sense of whether or not we're potentially dealing with a coagulopathy in addition to lower extremity swelling versus just lower extremity swelling overall. right? For example, if we do see that there's bruising elsewhere in the body or symptoms of a coagulopathy, we'll want to look to the med list, but also it potentially brings the liver more central into the picture, as Charmaine mentioned, given that the liver is responsible for the development of many of the various factors that are required for hemostasis. And so I think it's one of those things right now of like, do we incorporate that as a key feature of the problem, or just say that this is actually a known consequence of the primary problem that we're dealing with, which is the bilateral lower extremity swelling. And I think the jury is still out on that one, but it's one hypothesis that we're going to want to hold.
So I'll keep going. Amazing discussion so far. So now I'm going to give you like the PMH, and for time reasons, also I'm going to give you the physical exam. So for the past medical history of this patient, he has history of AFib, severe aortic stenosis, coronary artery disease, PCI was performed many years ago for 2 vessels. He also has OSA on CPAP, hypothyroidism, chronic kidney disease stage 3, and a prior subdural hematoma. For medications, he takes aspirin, atorvastatin, Docusate, levothyroxine, and vitamin D3. No allergies are reported. Patient has a significant family cardiac history in deceased father and mother, and has never smoked and has never used alcohol. No illicit drugs too. For the physical exam, so the patient is afebrile, heart rate is 94, blood pressure is 123/73, respiratory rate 18% with oxygen saturation of 96% on room air. So on the physical exam, generally, the patient looks like an elderly man lying comfortable in bed in no acute distress. Nothing remarkable in head and ENT. In the lungs, patient has bivascular crackles. In the heart, a hollow systolic ejection murmur 3/6, best heard in the right upper sternal border, no jugular venous distension. The abdomen is soft and non-distended, normal bowel signs. For the extremities and the skin, the patient has left upper extremity large hematoma in the antecubital fossa in the location of previous IV. A grade 3 bilateral pitting edema from the ankle to the knee, bilateral pigmentation from the shin to ankle with a slightly yellow discoloration, more proximally with red petechial rash. Left lower extremity below the knee, slightly warmer, more erythematous, and slightly larger circumference in comparison to the right, without any drainage. Also, the patient has a large ecchymosis on lateral aspect just distal to the fibular head. Pulses distal to hematomas are normal in all extremities. And in the neuro exam, nothing remarkable with the patient. So I'll stop there.
All right. Well, I will just touch briefly here on some of the things in the past medical history and the med list, and then let Charmaine take us through this really, really rich exam that we have here. And I would say, if we want to sort of evaluate, if we take the past medical history before we have the exam and use it to layer on to our original sort of framework for thinking about the bilateral lower extremity swelling, we start to see bright blinking lights start to center on the heart here, right? We said that there's sort of 3 primary organs, the liver, the kidneys, and the heart here. And if you just look at this individual's past medical history, right, all of the center of gravity is pulling us towards potential cardiac disease. If we think about what cardiac problems could cause bilateral lower extremity edema, heart failure comes into play here. And we see multiple risk factors here for the development of a cardiomyopathy, right? Pre-existing AFib can be a signal of underlying arrhythmic disease, as well as of underlying structural heart disease, because that's usually one of the culprit causes of the development of atrial fibrillation. So that could be a component of a non-ischemic cardiomyopathy. And then we also see a component of an ischemic cardiomyopathy here with the known coronary artery disease. And then finally, we also have the valvular pathology on the hook as well. So all of those things really focus our attention to say, okay, probabilistically, what we're dealing with is now sitting most likely to be a cardiac cause of this progressive lower extremity edema. But then we still have to answer the question of, well, gosh, what about the bruising? Is the bruising a bystander or a key feature of the syndrome here? And one hypothesis, again, is to say that, again, cardiac disease can cause lower extremity edema, and that could lead to bruising on its own, but also in the presence of certain agents that may predispose somebody to abnormal bruising or bleeding. And while we don't necessarily see anticoagulation on the med list of this individual with AFib, we do see aspirin, and aspirin can certainly predispose to the development of very, very easy bruising, even in the absence of trauma that may rise to the level of somebody's memory, right? So somebody bumps their elbow on a door frame or bumps it on something else as they're just moving through the world. A day later, they may see that there's a pretty significant bruise there. And so I think, again, we still have to contend with whether or not the bruising is a key part of our problem representation or just gets lumped into whatever is causing the lower extremity edema. But I do think that the exam can help us sort of further add nuance to that. And so I'll kick it over to you, Sharmise, to take us through that part.
Amazing, Jack. And just to layer on that amazing discussion, the first thing I always look at, again, is the vital signs, just to help me better understand how fast I need to think and move through things and to do things. And still relatively stable, which is good. If you're worried about bleeding, if you're thinking about this lower extremity causing hypoxemia, the patient is doing okay. So while walking through that and layer on, again, like we hear the systolic murmur of the AS. And I have this similar thought with aspirin, as Jack mentioned, that it can cause platelet dysfunction and more easily bleeding, especially with aging. The skin integrity, the vessels integrity, just you bruise more easily. And on top of that, aspirin can lead to it. The other thing to consider is that with like severe AS, sometimes you have the shearing of the von Willebrand factors, and you can be more prone to bleeding. I think the most famous case of that is like, bleeding through the GI, through the AVMs that a lot of people at older age had, like sometimes referred to as Heidi syndrome. However, if they can bleed from there, they can bleed from other places as well. And there's no JVP, but bibasilar crackles, especially if they're vet clackers, are good surrogate for being worried about pulmonary edema. However, getting further imaging and chest X-ray would be helpful. And sometimes JVPs are hard to evaluate on an exam, and sometimes POCUS and ultrasound was helpful in order to do that. In terms of like the extremity, sounds like a left greater than right lower extremity edema. You see often that just because of the way the vessels, the veins go through the legs. However, the always to think about is how ambulatory a patient is, or how if the patient is at risk of both clotting and thrombosis. If you're worried about dysregulations, then thinking about do I have to worry about a DVT on top of that, especially if the leg is warmer or things, less likely. Probably it's just the lower extremity edema. And I think in terms of the bruising itself, I don't have anything more than what we already discussed. I think thinking of the aspirin is a good thing, and getting some more labs and imaging would be helpful. Anything else to add about the exam, Jack?
No, I'm with you. I think, Austin is bringing up a really important point in the chat about spontaneous, like a spontaneous or atraumatic hematoma versus a sort of secondary hematoma, like from trauma or something. And I think that branch point does play a huge role. Like spontaneous hematoma has a very high signal for a coagulopathy. And I really struggle clinically to distinguish between the two, because oftentimes when someone says that, or I think oftentimes there's the risk of saying that something is a spontaneous or an atraumatic hematoma when the individual just may not remember the low level trauma that caused it. And so I oftentimes think about the parts of the body in which the hematoma is present as a really, really helpful finding, right? If we think about the parts of our body that we end up bumping throughout the day, it's usually more distal components rather than the axial skeleton. I bump my wrist, my elbow, my shins, my knees, my ankles on things all the time, just as a clumsy person moving through the world. Whereas other places like my abdominal wall, my chest, my back, these spaces aren't things that if they do suffer trauma, I'm much more likely to notice that, right? If I'm playing, doing like an activity outside and something hits me in the chest, like a ball or a frisbee, or if I'm walking down the stairs and I slip and I fall and I hit my lower back on, say, the stairs as I fall or on a railing, those will usually be much more significant traumas. And so I think at this point, from a probabilistic perspective, the fact that most of the bruises are on the extremities probably makes me think more likely that there's potentially trauma there, or that these are areas that are prone to trauma, right? The lateral aspect of the fibular head, as well as in previous IV sites. But as Charmaine said, the petechial rash is a little bit more atypical, and that might signal for some sort of underlying qualitative or quantitative deficiency in platelet or the coagulation cascade. So it'll be interesting to see how the labs play out. We may find ourselves in a space of thinking about abnormal bleeding plus normal coag studies. I think, that would be sort of at least how one way to try to tease apart whether it's spontaneous or traumatic bruising, as thinking about where the bruises are present and how likely those areas are to be subject to trauma in our day-to-day life.
Amazing. You're getting close to it. So let me continue now with some labs. So for the white blood count, we have a 13.6 with a normal differential. The hemoglobin was 10.8, and that was his baseline too, so no change with that. Platelets are 187, and MCV is 101. So for the CMP, we got some chemistries for this patient. He had normal electrolytes, but his creatinine was 1.35, actually the same as baseline. We got some troponins, those who are mildly elevated. The BNP was 1,123. TSH was 4.23. We got an EKG and it shows a first degree AV block. And with the chest X-ray, we got a left lower lobe airspace opacity. Other labs we got was the urinalysis. So the urinalysis dropped from 3 to 9 white blood cell counts per field and 20 to 30 red blood cells. The D-dimer was 3,090. We also got a bilateral ultrasound for lower extremities, and it showed no evidence of DVT. A transthoracic echocardiogram showed an ejection fraction of 75 to 70%, and it shows also a severe aortic stenosis and moderate mitral regurgitation. I think I'm gonna stop there and then I'll give you more information.
All righty. Marina, what a great case. Thank you so much. I'll go through half of the labs and then ask the amazing Jack to walk us through the rest. So I think, looking at the CBC, he had a little bit of a leukocytosis, but with a normal differential. Hemoglobin, the fact that I think it has remained stable from the last check is really, really informative. So I feel a little bit better about that. And then in terms of the platelets, like the number is okay, but again, like aspirin affects the platelet function. So that is still on the hook about contributing to some of this bruising. The MCV of 101 is interesting. And just a little bit expand on it. A couple of things that comes to my mind. We often think about like vitamin deficiencies, right? Like the B12, folate. The other thing to think about is like, reticulocytosis. If the bone marrow is keeping up with the blood loss, then you can get a macrocytosis because the bone marrow is just pumping out red blood cells that are bigger. So that is something to think about in terms of someone who you're worried about like bruising or bleeding a little bit more. And the other things, liver disease, hypothyroidism can also do it, and a bunch of other things from bone marrow. So that is interesting to me. And the fact that the other thing that I always look about when I think about like what else could cause platelet dysfunction is like uremia, and the fact that creatinine is at baseline, that is a little less likely. In terms of like the BNP, we've already been getting signals throughout the case that this person has a new diagnosis of heart failure. And I think BMP in the setting of, crackles, and the lower extremity edema, it's beginning to form another picture of like, oh, what is going on with the heart? And in terms of like a little bit of elevated troponin in this person is not surprising to me, given the extent of the coronary artery disease. I'm worried a little bit less about ACS, so thinking more whether this is just demand. So I'll pass the mic to Jack for the.
Amazing, Sharmeen. I love it. I think this is such a fun case. And Marino, thank you so much for outlining it the way that you have. This has been really a blast to think through. I think now, exactly as Sharmeen was saying, there's like the heart seems to be a major center component here. And then we have some other clues in terms of the cell line abnormalities and then also the coag studies. I think what we can do is, given that we have such an abnormal PTT, sort of start to anchor or center our discussion there and just say, okay, well, our first question then is, what are the potential causes of an elevated PTT? And these causes can be either inherited causes or they can be acquired causes. In somebody who's 96 years old without a history of prior bleeding episodes, we can favor an acquired cause of an elevated PTT. Just to review it, inherited ones are usually inherited deficiencies in certain factors like factor 8, factor 9, or factor 11, as well as factor 12. And then also von Willebrand's disease, which can be inherited, can also cause an elevated PTT. In the acquired category, it can be things like medications that we give people, whether that's heparin or DOACs, but then also certain acquired abnormalities in coagulation. One of the most common ones that we can see is something like an acquired inhibitor. So most commonly, it's a factor 8 inhibitor. And these acquired inhibitors can come up in the setting of, say, underlying lymphoproliferative disorders like lymphomas or leukemias, as well as in certain autoimmune conditions. And then we can also see acquired von Willebrand syndrome. And the acquired von Willebrand syndrome is an interesting one here to entertain, given the echo findings that we have here. As some others have alluded to, there is this interesting overlap, and I think Sharmeen mentioned this earlier, this interesting overlap between severe aortic stenosis and GI bleeding, which is called Hades syndrome. Hades syndrome is really an acquired von Willebrand deficiency, where as blood gets moved quickly across a severely stenosed aortic valve, it causes shear stress on the von Willebrand factor circulating into the bloodstream and leads to the deterioration of it. So these individuals get an acquired von Willebrand factor deficiency. So I think one hypothesis that we have here is we say, okay, there's an elevated PTT, which we can see in von Willebrand's disease. There's a syndrome of maybe abnormal or easy bruising that we see given these scattered bruising, and a very predominant syndrome of heart failure here. And we know that this is probably a significant valvular cardiomyopathy because we see that the heart has done so much work to try to hypertrophy and grow and get stronger, yet it's still in heart failure, right? So this is quite severe aortic stenosis with a very high ejection fraction, and probably underlying severe, probably a potential underlying severe cardiac hypertrophy. But this is a very tough disease to diagnose. And so we also want to pay attention to some of the other potential things on here, right? So we might want to do things like a mixing study to look for whether or not there is an acquired inhibitor present, right? If we do a mixing study and we see that the bleeding abnormalities fail to correct, that tells us that there's probably an inhibitor present in this person's blood, which may make us go and look for underlying lymphoproliferative disorders like a lymphoma or a paraproteinemia. So I think that is all of that is to say, we seem to have abnormal coags. Those abnormal coags are probably an acquired disorder. That acquired disorder could be an acquired inhibitor, which we can see in certain underlying hematologic malignancies, or it could be acquired von Willebrand syndrome, for which we have a clear culprit given the severe aortic stenosis. Other rare things that can do it are things like lupus anticoagulant, but that seems unlikely here in the absence of other significant VTE events that this person had. So I feel like that's probably where I would think about taking this case next, but I'm curious, Sharmeen, if you have anything else to add.
Nope, nada. That was awesome.
So This is the last aliquot actually, and also I have something to say about the hospitalization course of this patient. So first of all, this patient was diagnosed with community-acquired pneumonia, and he got treated with ceftriaxone and azithromycin, and it really resoluted his upper respiratory symptoms. So we repeated the coagulation tests, and it showed an INR of 1.1 and a PTT of 93. So basically they stood the same. We got a lupus anticoagulant and it was negative. The factor 7 was low, factor 8 and 11 were normal. The von Willebrand factor activity was high, the von Willebrand antigen was high, and the multimers were normal. So we got a mixing study and it shows that the PTT did not correct. So also we got to measure the factor 8 inhibitor and it was of 49 Bethesda units, so really high. Do you want to know the hospitalization course again? Right now, sorry, or?
Sure. Do you want to just like, yeah, take us there? Thank you.
Okay. Okay, so hematology was consulted due to elevated PTT and recommended to obtain mixing studies. The von Willebrand panel and lupus anticoagulant revealed the presence of factor 8 inhibitor. The patient was treated with high-dose prednisone, 60 milligrams per day, for acquired factor 8 deficiency. His PTT improved during the hospitalization, but his stay was complicated by the development of acute anemia, requiring PAC red blood cell transfusions, presumably due to bleeding of subcutaneous tissues. He was given 1 dose of rituximab while hospitalized and was discharged home. He completed a total of 4 doses of rituximab as outpatient with improvement of his PTT down to 37 and with no further evidence of recurrent bruising.
Whoa. This is what an amazing case. And I feel like it's always a good practice to go through the coagulation cascade and acquired coagulopathies. And this was like such an amazing case where we started with bilateral like swelling and we ended with factor 8. So thank you so much, Marina, for presenting this case. Any other learnings, anything that you want to make sure we talk about it, Marina, before we hand over the mic to Aisha?
Yeah, I have one learning, and it's something that I've heard a lot from Ravi and Prof. Rest too on the RLRs. So when I first saw this case, I saw that the patient presented with bilateral leg swelling, and it was presented to me like it was a CP Solvers case. So I was starting to go like, is the bilateral leg swelling symmetric? Is it more pronounced in any other way? And then try to go my way from that. But that gave me like something to learn from this case, because normally when we see bilateral leg swelling, we expect to see the left leg more swollen than the right leg. And I've seen that presentation before, but I didn't know why does that happen. So basically, it's because the left iliac vein gets like a larger, needs a larger road to get to the leg. So basically, that was it. And also, this week has been like the heme week. In Monday's VMR, we got exactly the same diagnosis, but with a different presentation. So I felt like it was adequate to present it today to show like the overlap with the patient on Monday and the patient today. So yeah, I hope everyone enjoyed it.
Wow. Yeah, absolutely. Thank you so much for sharing all of that. I can't wait to go and listen to Monday's case when I get home from work for another spatial repetition. And yeah, and I think the other ones would be interesting to know why this patient had acquired factor 8 inhibitors. I think there's a great discussion going on in the chat about, given the age, underlying malignancy might be something to consider here. But thank you so much, Marina. Thank you, Jack, so much. And Aisha, we're ready for you.
Hi. Can you see me?
Yes, we do.
Okay, so my internet is a little wacky, so if it slows down, let me know and I'll turn off my camera. But great case. Thank you so much for the case, and the discussion was amazing. So for teaching points, what I have today is, so we had a 96-year-old male that presented to the ED with bilateral leg swelling, and which presented with bruising. So when we have that case, we figure out if the bruising needs to be focused on or not, or could the bilateral lower extremity edema be leading to the bruising? In older age, they're more prone to leg swelling, and we have to think about the causes being from kidney, liver, and the heart. And when we have these causes, we look for any JVD, we check the state of the heart, we look for causes such as nephrotic syndrome, vascular pathology such as chronic insufficiency. And so we're thinking about if bilateral lower extremity edema can lead to bruising. It could be because of the increased hydrostatic pressure in vessels, or it could be due to the extravasation of blood vessels. When we look at bruising, we have to think about if there is bruising on other parts of the body, such as gingival bleeding, petechiae, and it could also be traumatic or atraumatic bleeding, which could be because of bumping your legs, arms, toes. We all do it regularly, surprisingly. And then when we look at the past medical history, we have to focus on the medications. And we have to look for any structural diseases when we're focused on the heart, any valvular heart diseases, and certain agents that can predispose patients to bruising, such as anticoagulants, aspirin. And moving on to the vitals, when we look at the vitals, we have to look at the skin integrity, especially with the elderly patients. It predisposes them to bruising a lot more. And and we look for traumatic causes such as bumping your extremities. And when we look at the labs and imaging, we look at if this patient was specifically taking aspirin. So we look for the we look for the platelets if they were affected. And if the BNP is very high, which would cause us to, we would focus on the heart failure causing the edema. And for the PTT, we would look for potential causes, which could be either inherited or acquired. If it's inherited, it could be due to deficiencies in factors 8, 9, 11, 12, or von Willebrand disease. And in acquired, which is most likely in this elderly patient, it could be either because of the meds, such as heparin or direct oral anticoagulants, or it could be something called Heide syndrome, which is the acquired von Willebrand syndrome. And if we're suspecting that, we look at the echo findings, because it's due to the high shear stress caused from the severe aortic stenosis. Yep, that's all I got.
That was so awesome, Aisha. Thank you so much for walking us through all the learning points. This was so great. Always a highlight of my week to hang out with you all. Thanks again for coming. Really appreciate all the incredible chat lists, and can't wait to go through that again as well. And hopefully we'll see y'all tomorrow. Bye. Thank you, Marina, again.